And I'll be talking later about patient involvement in the production of the national plan. But first, we'll be having Amanda Pleven, the Managing Director of the Alliance, who will be talking about the process and content of the plan. Just a reminder, as was on the slide that you may have seen when you came in, we will be recording the first half of the meeting, and that will go online afterwards so people can review it if they so wish. However, if you don't want to be recorded during that first half, you will need to turn off your camera. The second half will be answering questions, but it would help us greatly that as questions occur to you, you put them in the chat, because Jane Parker Colson, the PPI lead for the Alliance, will be monitoring those questions, and may need to group some of them to put to Amanda or to me in the second half of the programme. And as the slide said, we'll let you know when the recording is being turned off. Having got through that complicated introduction, I'll hand you over to Amanda Pleven, who will be talking about the National Cancer Plan.
Thank you very much, Ray, and good evening, everyone. As Ray said, I have the privilege of being the Managing Director of the Cancer Alliance in the East of England. The Cancer Alliance is truly an organisation that endeavours to bring together all the partners within the cancer community, and certainly some of the colleagues that are on this call, who may be individuals who are working out in cancer services, are very much a part of what we all do to deliver well and improve cancer services and outcomes for patients right across the East of England. As Ray said, I have the opportunity to share with you the National Cancer Plan, which was published in February. We have a small number of slides just to help guide us through some of what we believe are the most important parts of that plan. So please bear with me, and I hope that I can serve myself well in terms of being able to just access the document that I need. So if you would just bear with me, and if somebody could tell me, Jane, perhaps if you can see on screen a PowerPoint presentation.
Yes, we can see that, Amanda.
Excellent. That's very good. Excellent. Okay, thank you very much. And again, thank you for the invitation this evening to be able to share this with you. The first thing I think to say about the cancer plan, just by way of setting some context, is it is recognised for its ambition. For those of you that have had the opportunity to take the time to read the plan, it is bold in its intention. It intends to set both the aim and the ambition, but also the way towards the plan for delivering world-class cancer care in England, and that's absolutely what we should be doing. There is recognisably, as you would imagine, there is a degree of, and I want to say political rhetoric. What I mean by that is there is opinion in this plan about cancer care not being good enough. That's not unfair and that's not inaccurate, and I think it's really important that all parts of health and care take the opportunity sometimes to be reflective on those things that are done brilliantly and done well, alongside those things where improvement is required. So without further ado, and I'm hoping the slides are going to move forward, but they don't seem to be. Oh, they are. Apologies, I was being impatient there. So the first thing I think really to acknowledge is the cancer plan does build on the 10-year health plan that was published earlier on, and that document, Fit for the Future, I'm sure many of you are well aware, enshrines really three main, what are often described as the big shifts. The analog to digital acknowledges that in many places in the NHS, we are very digitally advanced. We do things in incredible ways using some of the kit and equipment and really world-class already facilities and technology, but we don't use it everywhere, and it's not as widespread as it should be. And some parts of what we do, certainly in our engagement with patients and with families and those that engage in the NHS, does feel really quite it's not contemporary. And so that analog to digital is a recognition of the things that we do in an analog way that really should be much more advanced. But it does therefore recognise that in order to do that, the intention is to improve for patients' access, to improve efficiency and to improve outcome. But it is important, I think, to recognise that the NHS is not a digital desert, but it does have a way to go. And in the second of the three big shifts is around sickness to prevention. We all recognise it is far harder for a patient, for a community, for a service provider, a public service provider, to manage when there is already sickness, there is already disease, there is already illness. And with cancer, the further progressed, the more challenging the outcome is for patients to have a good outcome. And so recognising those early stages, using population health, public health information and data, and really thinking about how we work to ensure that we can identify earlier those primary prevention steps. And as we all know, the earlier really on cancer is diagnosed in terms of stage, the better the outcome for the patient. And the final one of those shifts is around what's described as hospital to community. Hospitals are fundamentally such an important part of the NHS. We all know this, and things that are done within those physical buildings are extraordinary. The people that work there are equally extraordinary. For any of you that have read the COVID-19 outcomes, we know this. But the provision of services doesn't always have to be from a hospital. Sometimes that's not in the best interest of patients, it's not in the best interest of community, and it can exacerbate health inequalities where it's difficult to be present in a hospital. So to support people really both at the diagnosis stage, at the treatment stage, and for those that are living with and beyond cancer, it's really important that we think about community provision in a very different way. So moving forward, and I know that Ray will touch on this later, so I will do this one lightly. What we're acknowledging here is in writing a plan, it wasn't a kind of a small number of experts sitting in a darkened room. There was a huge call for evidence and to listen to the views of the public and patients. And so more than 7,000 people who were either currently living with or had experienced cancer responded. And also the people that care for people with cancer equally responded. And that's really important to acknowledge just how many people were influential in the writing and in the delivery and in the creation of this plan. And the expert reference groups that I suspect Ray will talk more about were a fundamentally important part of that. Can't say the patient is at the heart of the service and not even have listened. Cancer Plan didn't do that. It really worked hard to listen and to allow that influence to be important in the writing and the delivery of the plan. But the acknowledgement and the words that are at the bottom of this slide is that recognition that we have the opportunity and we have the responsibility to do better. So trying not to be impatient again, but I'm pressing to the slide forward. Apologies. There we go. Three ambitions that the Cancer Plan has. The first of which is the way that we measure how good cancer services are in performance terms. So how well are we serving patients? And when we look at metrics and numbers and statistics, it is always with the recognition that behind every one of those numbers is a person, is a patient. But there are three overarching and main, if you like, cancer waiting times, as we refer to them, standards. And the expectation, the ambition in this plan is to meet all of those standards by the end of the Parliament. And those really focus on faster diagnosis, so confirming ruling out cancer within 28 days, on 31 days, so a decision to treat if indeed it is required and the person has been diagnosed with cancer, and within the timescale of commencing treatment within 62 days. And the reason therefore that we call them waiting time standards is everyone thinks about, every one of those standards thinks about how fast we can move patients in an accurate and timely way through the pathway. So it's the first of the ambitions. The second one is in the acknowledgement that we don't just want to find cancers earlier, because that's half of the challenge. The second thing is to treat people in a timely way, in a precision way, and in the best way due to informed consent and consideration for that patient to achieve the best outcome. So the second ambition is that 3 in 4 people, 75% of people diagnosed with cancer will be cancer-free or living well with cancer after 5 years. So that shifts that intention from being early diagnosis, 3/4 of patients should be diagnosed at an early stage 1 and stage 2, to that is a good ambition, but we need to go further than that. We need to do more than that. So this is now saying in order for people to be cancer-free or living well with cancer, they need to have been treated properly and treated well. And therefore, that's why this almost evolves that earlier ambition. And the last of the three really talks about improving the quality of life for people, recognising now that cancer is a complex disease. You all know that very well. There are multiple types of cancers, and evermore there are the nature of some cancers where people can live for a substantial period of time very well, or they can indeed reach very old age and live and die from rather than die with rather than from things like prostate cancer. So there is a recognition that cancer has changed, and that's in our lifetime, in our generation. So we want to improve the quality of life for people, recognizing that cancer now has a different shape, it has a different composition. So I should learn, shouldn't I, to press the button before I need to move forward. And I'm so sorry that these are, well, not these are slow, I am slow. Okay, so I'm going to move past this quite quickly because the next 6 slides, and for the eagle-eyed amongst you, you will see there's a 7th theme, recognizing what it is that we want to do specifically to achieve the 7 key themes that sit underneath, if you like, and behind those ambitions. The first of which is to drive up NHS cancer performance. And this is this is one of the metrics that I was talking about earlier in the cancer waiting times. It's shown on a graph on the left-hand side, and this is the 62-day treatment target. So the intention is that 85% of people who are diagnosed with cancer commence their treatment within 62 days of that urgent referral, that urgent suspected cancer referral. And you can see on the graph, which goes back to 2009, 2010, that whilst for some time we were almost above, just above the 85% target, we really started to pull away from the target. And by the time we reached that very challenging period in 2019, 2021 of the COVID-19 pandemic, we were moving away from that target. So there is an intention to move back towards it, and that's absolutely right that we should be doing that. At the top of every one of these slides, and I'm sure that Jane will share them afterwards, is a statement that is made by patients. And I think it's really important that we recognise that that voice that I talked about earlier is absolutely part of the way that this plan is written. So all of these intentions, all of these 6 start with what is it that the public and patients have said. So we need to improve cancer performance. How are we going to do that? And in the plan, we have a number of commitments. I'll just draw attention to some of them, but I know that you are all very capable to read them. So to do this, to drive up cancer performance, we need to harness innovation. Much of that in things like fit testing is already in the NHS and used very well, but there is certainly more that we need to do using innovations that enable us to improve that performance outcome for patients. And prioritising, for example, NHS Online, and NHS Online for cancer patients would be around, for example, providing digital access for tracking diagnostics, for treatment information, and having supportive applications or supportive apps in there around things like psychological support. So using NHS Online to great effect. And expanding diagnostic capacity, community diagnostic centres, which we are reasonably well provisioned with across the east of England. We need to make sure they're open, they're full, they're being used well. Things like teledermatology as an opportunity can be very well provided in these places that are in the community rather than necessarily all in hospitals. And finally, that's sort of in that diagnostic space. At the moment, it is much closer probably to 75 or 80% of histology results that come back in that 10-day expectation. Histology can be challenging dependent on the complexity of the sample that is taken, but the intention, because we know how important it is really to drive away from that 10 to 14 days, much closer to 10, and move up beyond the 80% really to something much closer to everybody's results should be back. Again, to be fair to my colleagues that work frontline and on the ground, there are times that histology results are turned around within a singular day, depending on the complexity. That's in rare circumstances, but I think when we think about those things that need to be done, we also need to recognise those things that are currently being done by those extraordinary individuals who are working frontline. So just an acknowledgement that there is good practice, but it needs to be everywhere and all the time. So the next thing of our 6 is improving cancer outcomes. So it's all very well that we've driven up performance, but remember that ambition about 75% of people, 3 in 4, and what you see on this graph with those lines, for those that can't see colour, that top line is from from 2005 to 2020, because this data is time lagged, that's the position relevant to the improvements that have been made in 1 year survival. The next line down is 5-year survival. So obviously you can see that that line stops shorter because we're currently recording at that stage. And then 10-year survival, which not surprisingly is closer to sort of 40%. So that's the lowest of all the survival rates. Again, in some of the cancers that are rarer or are progressive or are very difficult to treat, we acknowledge that that long-term proximity, that long-term duration of survival can be reduced. So there's an acknowledgement here that we want to improve cancer outcomes, and that in part is about survival. So using things like lung cancer screening, which we all know from a health inequalities point of view is an extraordinary program and does incredibly well, making sure that we enable and empower patients to use things like the NHS app, and also thinking about symptomatic case findings alongside using genomic testing as a good way to ensure that that's in the part of driving patients very quickly into services where they are required and identifying cancer at a really early stage. And in, for example, those symptomatic case findings, being able to use it in intelligent ways where potentially alongside the asymptomatic things like screening, we are really using campaigns to make sure the public are fully aware of what a symptom could and should look like. And many of you will have seen those media campaigns that endeavour to ensure that the public is well informed to step forward should they need it. And specialist treatment centres, it is extraordinary when we look at the advancements in complex surgeries and chemotherapy and radiotherapy as the modalities for treatment for cancer. And the more that we can make improvements in those highly specialist areas, the better we will be able to treat all cancers and everywhere. So there is an acknowledgement it's a highly specialised disease area, and those cancer treatment centres enable really good outcomes for patients. And every time we meet with clinicians, there is the consideration by them that it's never going to be good enough. But when they do take the time to be reflective, the recognition of patients who would once not have survived, or patients that would not have survived as long as now they are able to do so, can sometimes come down to that treatment and how extraordinarily well the people that work in those places serve our patients, and how empowered, informed and educated patients are in their engagement. Again, not everywhere, and there is work to do in that space to make that much more equitable. And finally, multi-cancer early detection tests. We've seen things like the blood test in Galleria that was used quite successfully and trialled, but we want to make sure that there is a greater prevalence of those kind of tests to enable us to improve cancer outcomes. So people designing cancer around people's lives recognises that as this disease has progressed and we have become better at diagnosing and treating, so the population, the people, all of us have also, we lead very different lives in many places and for many people than we did maybe a generation ago, and thinking about how people want to stay in or return to work, ensuring that patients are able to provide real-time feedback through things like the PROMS measures, having a prehabilitation offer so that people are ready for treatment and their treatment best supports them, and ensuring that every patient has both a holistic needs assessment but personal care plans with regular reviews that don't just support their physical but their mental, social and employment needs. And all of these things are really important. So having a named care lead for each patient to coordinate the post-treatment in some of the ways that trackers or CNSs or cancer or those local provisions already serve patients well, but this is enshrining an intention to do that everywhere and for all patients. And that's important as we utilise things like chemotherapy at home where that's appropriate, and with patient consent, it's an intention for treatment, so that managing cancer, living with cancer and being treated is something that is affecting the patient's life in a way that perhaps can be advanced, as opposed to, and patients yourselves, I'm sure, will recognise that sense of life is on hold for a period of time. We want to work to support patients so that we can design the care around people's lives and not the other way round. The fourth thing is around research. Now, we know in the east of England, we may be incredibly privileged to have a cancer research hospital built in the east of England and to serve and support our patients to deliver world-class research with partners like the University of Cambridge and other extraordinary and world-class academic institutions and research organisations and companies that work in the space of medications and diagnostics and tests is really important, because to enable us to deliver world-class cancer care, we have to think about that research element of it. And I'm thinking now beyond clinical research trials. So of course, expanding access to trials is important, but making that faster and fairer and launching a clinical trials accelerator program is one of the commitments of this plan. Equally, there is this intention in the National Health Tech Access Programme, I can never quite remember that, which only launched in February of this year. There are 4 new diagnostic technologies. Now, when we say new, capsule sponge isn't new to many of us here, and also prostate and breast tissue sampling, again, it's not new, but the way that we want to use AI and technology to support the investigation and interrogation. Detection tools for endometrial cancer is the third of those 4 new technologies or advancing technologies, as is chest X-ray analysis. So there is an intention to speed up how we prove innovation so that we can use them everywhere, and also setting the research priorities around all of those things that we know accelerate progress, and certainly ensuring that across the country, across England, cancer immunotherapies delivered through the vaccination innovation pathway and programme does need to ensure that we are intending on delivering those targets, those numbers. And for the east of England, there will be the appropriate intention to do exactly the same thing through our partner organisations, because those research areas will absolutely continue to help us to drive against those ambitions. So our final 2 things are recognising children and young people's cancer. And certainly one of the pieces of feedback that I think I have seen recently in the east of England through our extraordinary patient partnership group is only very recently a patient's father who joined the patient partnership group and talked about the experience of children of a child's cancer. And Jane is looking at me because I didn't join the beginning of I think the gentleman was the father of the child. Jane is now nodding. Thank you. And my apologies, for it just felt appropriate to check that I was correct. It is one of the most difficult things I think that all of us recognise, in that place where the opportunity for a preventable death has to be explored by doing everything that we can possibly do in this space. So there's some commitments in practical terms in this plan about travel costs and, you know, making hospitals more child friendly, and those are honourable and the right intentions. Some of the things that are really enshrined in here around readiness for the psychosocial and long-term support is equally important and imperative, but ensuring equitable access to things like genomic and research for children, young people and or teenagers is so important, as is the early detection and diagnosis. So there is much that we have to do. There is new specification in this space around ensuring that we really do get this right. And I think, as an example, when we think about having neurorehabilitation key workers for children who have central nervous system tumours, that's the kind of very practical thing that we should absolutely ensure that we are doing right across the east of England, and we are developing and evolving the way that those key workers could support children in that space. So this is a really exciting part of the cancer plan, because it encourages and allows us and ensures that we feel accountable for the ambition that is in this space. So the 6th of those areas, when I said that there were 6 parts or sort of 6 main themes in the plan, the last of which is prioritising rarer and less common cancers. So sometimes these are the cancers that can be fast progressing, can result in a terminal prognosis, and they are the places where we do know that in that recognition, almost public recognition, when we think about cancers, this kind of pathway for a patient, this kind of experience is often what many people think about when they think about cancers. We all now know that there is a whole breadth of different kinds of experience depending on the type of cancer that a patient has. But in this place, what this plan acknowledges is that we need to get much better at diagnosing those rarer cancers earlier. We need to improve access to those treatments, and prioritizing things like genomic testing is one of the ways that we will be able to support to do that. The rare cancer bills, which again was only this year, it was March, accelerates research, it improves data access, and it ensures that we have good access to trials. All of that now enshrined in that intention. And to have, I think, that kind of political support, if you like, in policy terms, to improving and prioritizing rare and less common cancers is a very intentional thing. And when we talk about accelerating research and innovation, it's absolutely right that we do that specifically here. So as I said, there's 6 intentions, but for the eagle eye, there is 7 parts of this plan. And the last one, we often used to talk about quality being that underpinning foundation. It runs across everything. And it's just as important that we talk about health inequalities in exactly that same space. And the call for evident respondent statement that is on here is around the recognition that for lung cancer, the dangers of tobacco are well documented, but that person felt that perhaps the public isn't still quite aware of physical inactivity, obesity, and other things that can be pertinent in that likelihood and prevalence of cancer being diagnosed in any individual. So this plan commits to continue to roll out cancer screening and surveillance programs. We've all known and seen the extraordinary effect that the lung cancer screening, as it's now known, program has, enabling us to treat 70% of patients at an earlier stage by the fundamentals of this program, as opposed to less than 30% in our sort of more standard and traditional ways. And the change in that has been those areas of high deprivation, those places that we recognise health inequalities, are now better served than other places that have areas arguably that have less deprivation. So, and that's a complete change in that profile. That's the kind of work we need to be doing more of. So local targeted campaigns, recognising where there's gaps in those other 3 screening programmes, that's the work that we need to do. Those are the commitments and the underpinning pieces of work that the Cancer Alliances and its partners will continue to do. And health literacy, we talk about this, but making sure that empowered patients are able to continue to provide not only influence and impact in the work that we do, but it's the recognition of using tools, not such so that we are simply communicating, but that comprehension exists. And that's just an example of the recognition where sometimes we use apps and potentially using AI as a part of the delivery, but using an app, but it's got to make sure that it works for the individual, works for the patient. So that, again, there is an opportunity in that space to help us reduce those inequalities that exist. And certainly recognising how we use data and insights to reduce those gaps will continue to be ever more important, so that between most and least deprived areas, we close that gap, we make that reduction. And the 2 final slides that I have for you today, and then I will stop talking, and I hope, Jane, I've taken the allotted time. What about Cancer Alliances then? What is the role that we have? What is it that we are endeavouring to do? And really, we describe ourselves in that truest sense as an alliance. We have the opportunity and the responsibility to drive improvements to ensure that there are good outcomes and that performance improves where it needs to do so. So we have some key responsibilities that are enshrined in this slide around improving support, using insights, making sure that quality improvement and quality improvement collaboratives are in place to review them, to identify outcome goals, and to hold ourselves and others to account for that work. Localised neighbourhood care, working with communities, people that know better how to tread the pathways we describe as hard to reach in a very different way. And ensuring that we're transparent and we're accountable. So reporting not only to the parts of the NHS that it's entirely appropriate we report to, but ensuring that relevant data is available publicly. And in that space, the alliances also have an opportunity to enable research and innovation to do all those things that we have described as doing, which all comes back to the overarching aim to improve cancer services for patients. I said 2 more slides, my apologies. This is the penultimate slide. We wrote a strategy in 2022, we updated it in 2024, and we're now at a time where we need to think about, we've got a national cancer plan, how do we need to think about our strategy? And when we've looked again at that and refreshed our priorities, there's no surprises that the things that you see on this slide are exactly those things you would expect us to be looking at. Early diagnosis, reducing emergency presentations where for a patient that's often late stage and hard, building those awareness campaigns, supporting our GPs, even those that don't have cancer as a specialist interest, in that prevention and outcomes agenda. Getting better, reducing variation in 28-day faster diagnosis, 31 and 62 days. In the East of England, we have some of the best performance in the country. And at ICB level, we have some strong performance. And at a regional level, we aggregate in quite a challenge way due to some of the complexity in some of our more complex organisations, but we will never stop endeavouring to make those improvements. And workforce, skilled, sustainable, committed, passionate. The last 2 are already there. We've got to make sure that we can reform workforce by investing in both training and thinking about new roles. We can all see or hear what is played through in terms of the NHS has received more money. Do we have as many doctors or nurses or therapists as we need to? But the reality is we have to think about reform as well as just more, because there is no more in some of those difficult spaces. So there is a recognition that a sustainable workforce has to be a reformed workforce alongside investing in the roles that do exist. And in that sort of personalised place, in neighbourhood-based, local-based, tailored provision, one of our intentions, one of our refresh priorities is to align very much to those local intentions and the new ICB footprints that we have in the East of England. And finally, to think about innovation and research. And I've certainly said probably enough in that space. And so the final thing that we did was to think about the National Cancer Plan and the East of England Cancer Strategy. And we simply pushed this through all of the AI models that we now utilise on a reasonably regular basis to have a really biased and objective way of saying, does the East of England Cancer Strategy, or the things that we are committing to do they make sense? Do they read across? Are they pointing in the same direction as the National Cancer Plan? And all that this slide shows us is if we think about some key areas and we look at the National Plan, and again, an objective measure of how are these things described? How is the whole pathway focus described in the National Plan? There's some feedback in terms of whether it's strong or it needs some more work or it needs a refresh. And certainly in terms of how we serve our patients, we were really keen to do this work so we could guide ourselves in the places that maybe we needed to do more and recognise where we almost had it in the right place. The alignment is good, and it helps us to be able to identify those places that we need to move forward. The final thing I did want to say is just to acknowledge and to say thank you to the extraordinary work that is delivered by the frontline staff right across the East of England. Cancer is a difficult place to work, but it is also one of the most rewarding in the NHS. And all that we do in the Cancer Alliance and with our colleagues always leans towards patients and the outcome for patients. But I think it was entirely appropriate to recognise the Cancer Plan has ambition to support those people do their very best so that together we all serve the patients. Thank you very much.
Thank you, Amanda. I would like to talk briefly about the patient involvement in the production of the plan. Amanda has already referred to the external reference groups. At that stage, there were 6 themes which were being developed separately, if you like, in silos, which I suppose gave the initial concentration. And the East of England Patient Partnership Group has 3 members on the National Patient and Public Voice Forum, and each of them was involved in the external reference groups. I was on the treatment group. I mean, it's a typical sort of NHS meeting, 26 people in the room, albeit virtually, 2 patients. But it was good because the chair made it clear that she wanted to hear from the patients first. And that was a very good start to the process. I think that of the plan, the most important part is designing services around people's lives. At the moment, it's not always the case. Some years ago now, but I think still relevant, we had in the patient partnership group, we had an interesting presentation from someone whose husband had a very complex diagnosis and treatment. And although they lived in Essex, most of that treatment was being delivered in London. And one crazy example, before treatment, blood tests were required, which meant that the way it was organized was that they had to spend the best part of the day driving to and from London so that the guy could have a blood test, which is not the way services should be designed. And I hope that the personalized care will come through. Since the plan has been put together, just prior to the launch, 10 of us from the National Forum were invited to a reception hosted by Wes Streeting. And he made it absolutely clear that those of us, not us, just us, but community services, voluntary services, and specialist bodies which look after the patient voice with specific kinds of cancer, different tumor types, all of them would continue to be involved in the delivery of the plan. And so far, so good, because we've had a meeting with Ashley Dalton, the junior minister at the time, who currently has breast cancer, and she emphasized the point. And since then, we've also had 2 meetings with promised further meetings with David Fitzgerald, who's the policy lead within NHS England. So I'm reasonably confident that this is going to work. But I have to say that we need to be very vigilant. Patient outcomes are clearly the most important, and improving patient outcomes will bring great benefits. But we have to bear in mind that if the patient has to go through very bad experiences to get to a good endpoint, it could destroy the benefits which that patient should be getting from having successful treatment. So just very shortly and in a nutshell, those are my reflections on where we are with the National Cancer Plan. And if we're going to get to where the plan wants us to be, then the patient voice will continue to be hugely important. Thank you.